Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content.
I actually set a goal back in June. It was a very clickbaity goal. I'm going to Jefferson curl 225 pounds for reps or blow a disc in my back, whatever happens first by the end of the year. Spoiler, it's November 10th and I'm still healthy. I think I hit 210 pounds last week.
Welcome back to the 8-Minute Rule. We've got Mark and Drew here with me, and we are going to be discussing the basics from an exercise standpoint versus novelty. But first, here we're going to start off with a nice little icebreaker. So around exercise, for Mark and for Drew, if you could prescribe one exercise, only one exercise, the rest of your career as a physical therapist, what would that be and why? Drew, start us off.
So if I'm going one that hits a little bit of everything, and it's kind of hard because I usually can break it down, but a Turkish get up is like, it is core, it is upper body, it is lower extremity, and is a lot of the things we do kind of combined into one. So that may be the ultimate one because it's like 5 different things at least in one.
I appreciate that. You think, Mark?
I was kind of thinking along the same lines, trying to get bang for your buck, so I went with a clean to press. So you get the deadlift portion, you get the squat portion, you get like the shrug portion, the like almost like the kettlebell swing portion, and then you get the whole overhead press. So
I like it. It's good stuff. Yeah, I was kind of thinking along the lines of a single arm kettlebell clean to press. So kind of in that same setup, but you get to do both sides now, so comparatively there. So yeah, like how we're all thinking, engaging everything there. So I appreciate that. So again, we want to dig in a little bit today. You know, everybody has seen the different exercises on TikTok, YouTube, even on LinkedIn, and you know, I think sometimes it's pretty neat. You get to see a couple that look like they could be really effective, and maybe some professionals are having some good benefit with those. I know also, knowing both of you guys, that you are definitely well versed in the basics, and you talk about how important those things are. So we kind of want to look at just the difference between the novelty of exercise and kind of knowing the basics. So first question, when you in your clinics, you guys have both trained and mentored a lot of new grads. Do you tend to see new grads overusing the basics or overusing novelty exercises? Let's fire away to Drew first.
Gosh, I don't know if I see a consistent pattern, to be honest. I think I see some who tend to get stuck with the very basics and have trouble going from there to where the patient is in front of them. And then I see some who just totally miss the basics because they want to do something different or exciting and think that is something novel is more important than some of the basics. It's honestly, I think for me, it's a big toss up of some are way too basic and don't think outside the box, and some only go outside the box.
I think that's a good way to put it. It's kind of the inconsistency. I know from my personal experience, I was kind of on the extremes where I would do like the really basic stuff and then like take a huge leap into like the super extreme and like weird things, and there was like nothing in between, nothing in the middle, and it was just not good.
Yeah, I think well said. And you know, our job with new grads and newer students as well too is to really help mentor them in that space. So you know, not to be unexpected there at all. For you guys, what's when you're looking at different types of exercises, especially when I know you guys are big proponents of the basics to some degree. What would your criteria essentially be when you're looking at a basic skill? And basic exercise is obviously going to be the lunge, it's going to be the squat, it's going to be hip hinge. We're talking about a lot of those. At what point do you feel like you can be able to see that is able to move into a higher level drill? So when you're able to kind of see patients progressing to that. Any thoughts on that, Mark?
Well, I mean, they have to be able to master the cardinal plane movements before you start to add in a ton of combined things. If they fall apart with a reverse lunge or a side lunge or even a forward lunge, those are all 3 cardinal plane movements, right? If any of those are not what they need to be doing or not proficient, then they can't then add in, change of directions and twists and stuff when planting or running or things like that. So they have to show that they can do those things before we even consider going into the next level. And then, when you are considering going to the next level, which may be, it may be even just like, it may be you're trying to get into lunges, or it may be that you're trying to actually introduce change of direction with running. They have to be able to demonstrate that they can hop in place. They can hop in several different directions. They can do all of these things before you start to put it all together. It's kind of like the power clean at the beginning. Like, you have to be able to do the deadlift portion before you can throw into the power clean. You have to be able to do the front squat portion, the shrug portion. All of those pieces have to be there before you can put the whole thing together.
Yeah, I like that. So obviously you want to see that your athletes can be able to lunge in every plane and do it well before we're throwing them on a Bosu ball, doing some other goofy stuff. So absolutely. Drew, how about you? Especially from the standpoint of maybe low back or neck issues, looking at some basics, and then when you're ready to see them start to progressing, what they need to be able to do.
Yeah, I think for me, I look at a couple different things. One, do they have the movement or the motion available in order to do the movement? That's first and foremost. And sometimes in that, like, some of my reasoning might be, do I think they'll gain it at some point to do it really, really well? Or how can I modify the movement for what they have available? Then the second thing is, do they have the control, the motor control to do this? I think when we start going from, and so just a little bit of a bias is when you think lumbar, even neck, something like that, we talk about stability a lot. And I think a lot of the research shows if you're for low back pain, like if you take a stability, which I hate that term, a motor control approach versus progressive loading and big picture things like lifts, big picture strengthening, big movements, complex movements, the outcomes aren't any different necessarily. But I think that's missing a step there and saying, does this person know how to move well? Do they understand how to pelvic tilt? Can they dissociate lumbar movement from their hip? Do they have the ability to do those things? And that's like first and foremost for me is, can you control kind of each joint in the different planes on your own before I like take you up into a more complex movement? And I think that's some of the reason maybe why these outcomes are like, oh, they both kind of work and one's not superior. I don't think you're differentiating the patients into maybe the correct place. I'm also not a person who says, hey, when I have this motor control, now I have to make it super complex. I need you to hold your hollow body hold while you're moving your arms and legs like a million different ways. Like when you start to get it, I want to start to get you moving and loading in more functional movements. So I think there's something missing within the research there. But yeah, movement or motion, do you have motion available? And do you have the motor control across those joints to know when you're moving, what you're moving versus everything kind of together to control them separately if you need? Because, if we want to make a change and you have no clue how to dissociate lumbar extension from hip extension, it's going to be a little bit harder.
Yeah, I like that. So for you, and I probably should ask this before going into that question. So Drew, what are your basics in terms of back pain? Like what are you going to have to make sure that patient's doing well before you're moving on?
Yeah, so I'm going to start with like the end in mind, if that works. So for my low back, I want them to be able to do a lift, a carry, squat, maybe like a lunge. But like those are the basic movement patterns that I ultimately want to get to. So depending on where the patient is, I may have to vary in order to work my way there. So one, do they have the movement available? That's kind of up and down the chain, everywhere from the foot to the hips to the and the controlled. I'm usually looking, do they have the association from the hip and lumbar spine? Or when they're trying to do a bridge, are they just like using their back and going into extension? They don't know how to use and fire their glutes. And then like if you're looking at some sort of hip abduction, are they moving everything at once, or are they able to control one and move the other? So it goes everywhere from like a supine or a side lying from like pretty supported where you're trying to cue them to move and stabilize the spine and move here, or stabilize here and move just the spine and dissociate those, up to into more maybe a seated or a kneeling position, then all the way up into standing, and then getting to all the other movements like that. So I do love some SFMA ideas of, they have like a supine and then a suspended and then a half kneeling and then an upright. So like those are some of the progressions you'll move to. So you think about hip flexion and extension in those position, and then can you get it seated on a ball? So like the hip ones, it'd be like the bridge and or a clamshell hip abduction, pretty basic straight leg raises where it's lifting, or you're controlling and doing marches and pelvic tilts. Can you do those separately? And then like, can you get up into sitting and on a ball? Can you do pelvic tilts on a ball? So there is some dissociation there. And then can you do this in standing and start doing hip hinging and moving into those movement patterns? So I kind of go from requires less stability because you're supine, then suspended, half kneeling to standing. And as you're going through those, can you dissociate hip, spine, or hip and spine to get upright? And then I'm going to start loading.
Cool. Awesome. Yeah, no, I love that progression. I mean, walking through, there's a ton of really good pearls in there. Mark, just kind of taking a slightly different direction. Obviously, you work with a lot of athletes, just kind of a thought process around give some pearls working with highly trained athletes. How are you going to keep them engaged without making their rehab program too complicated?
So a lot of it is still going to be the basics, and it's going to be pretty regimented. We're using very specific, like, objective measures that we're tracking over time and working to improve those objective measures. So, I mean, if I'm trying to improve their, quad ratio compared to their other side or compared to their body weight, like, they have to be doing quad exercises. And so a knee extension machine is very basic, but it is very effective at strengthening quad muscles. And so to an extent, when you give an athlete a target and a goal and are objectively tracking it, a lot of times that's going to keep them really motivated. Like, all right, I'm trying to move the needle in a direction here. Now, that works for a lot of times, but over the course of 9 to 12 months, sometimes that you're doing rehab with someone, you're going to have to mix it up, both for your sanity as well as theirs. And so I think, you still want to make sure you spend enough time doing the basics and getting adequate load with the basic movements, but throwing something a little bit weird in there every now and then to kind of challenge them dynamically, challenge their brain and their coordination of their nervous system from brain to extremity and back. There is value in doing that as well, particularly towards the end of rehab, but even along the way, I think there's value both from an engagement standpoint as well as challenging them in just a little bit different way.
All right, having trouble with my mic here. Yeah, great. I think one of the things I love that you hit on, Mark, was just the idea of obviously you're still trying to work the basics, but it is okay to throw in some other things. And I think that's really cool when you think through, just really feeling your patient out. Some of them, there's going to be some durations of care that are going to take a long time, and you really do, people's PT burnout to some degree from the patient side of things is a real thing, especially as you know, ACL post-op, stuff like that. So, there's a big value to being able to keep them engaged, finding ways for it to be competitive, finding ways for them to have those targets, which I think is why it's such a big deal to have kind of the test retest model in there as well too. So good stuff. And I think that's a great kind of at least takeaway from both of you guys is you got to have the basics down. And you can absolutely throw other stuff in, but if you don't have the basics down and you're not evaluating that the basics are taken care of, you're really not doing people a lot of favors.
I like the saying that I'll use, and I think this goes for both patients and for PTs. You've got to walk before you can run. And so the patients, they've got to be able to do the basic things before you start throwing these more complex things at them. And then also for PTs, like, you can get as creative as you want to be. There's definitely time and place for that, whether it be for that engagement purpose or each patient has different goals based on their job, whatever they want to get back to. You kind of have to be creative to maybe get them where they ultimately want to be, but they have to be able to do the basics as well, or you have to be able to coach the basics in order to get them to that point. So, like, I always think I have a pretty wider base of exercises for the patient when they start out because they're all at different levels. It kind of moves into here's the movements I want to focus on, and then it kind of gets wide again of like, all right, where are we taking them?
Good point. Good. All right, guys. Appreciate the thoughts. As always, really helpful. Thanks everybody for tuning in. And until next time.